Good morning, everyone. We're just going to give 1 more minute or so, then we'll start. Okay, good morning, everyone. I think we can start. For those of you that are on time, I'm sure there will be more people joining. So this is the last Trauma and Emergency lecture series for the year. So thank you so much for the whole year of participation. We're really looking forward to continue this next year with some exciting topics to follow. So the program will follow shortly. Then we had just an overview for the last 3 was about toxicology in the emergency department. So we're going to end with Dr. Nikita, that's going to present also some toxicology to us. Thank you very much. She's also an emergency physician, working with, together with Dr. Victoria Stevens. So thank you so much for your time. We're really looking forward to your talk. This is a very interesting slide. So I'm sure what you're going to share with us is going to be quite interesting. So over to you, and thank you very much.
Okay, thank you, Leanne. Morning, everyone. I'm Dr. Nikita Plamers. I'm one of the EM registrars. Tori has been my mentor and my supervisor for many years now. So yeah, this is my passion. This is what I do. I am an avid Harry Potter fan, if any of you are as well. So that's why the slide looks like this. But basically, I'm going to be talking about calcium channel blocker overdose and the management in ED. And I think that this is quite an important topic because hypertension is a very common comorbidity. It has a 30.4% prevalence rate in many South African households. And calcium channel blockers are recommended as the first-line therapeutic agents. So they can actually be exploited in the form of overdose, and this can actually result in fatal consequences. And then just some stats from like the United States of America show that calcium channel blocker overdoses are responsible for more mortalities than any other cardiovascular agent, and it has an estimated mortality rate of 42%. So it is quite an important topic that you need to know about when you work in the ED. Yeah. So I think the best way to learn for me, especially with talks, is learning from actual case presentations. So this talk is based on a case, actually my first calcium channel blocker overdose that I treated when I was a ComServe. But yeah, let's jump right in. So this was a 20-year-old male. He presented to the ED at about 3:30 with a history of ingesting multiple tablets that was mixed with rat poison at about 8 a.m. that morning. And then upon further questioning, the patient confirmed that it was intentional due to social and personal problems. His symptoms, he was feeling dizzy, he was weak, and he was experiencing lower abdominal pain. And then on examination, his vitals, he was hypertensive with a blood pressure of 81/27, a pulse rate of 88, normal SATs, and a mildly elevated respiratory rate of 16. The rest of his examination was unremarkable. In some special investigations, so his initial ECG was this. It showed a pulse rate of 75 beats per minute with absent P waves, and he had a widened QRS. And then this was his ABG. It showed this raised glucose of 13.8 and a mildly elevated lactate of 2.8. Okay, so who done it? Working in the ED, you actually have to be a medical detective, especially with tox cases. And you always need to ask the patient or the escorts what medications are in the house or what medication fellow family members are taking, as this can actually give you a clue. So in this case, the patient's adoptive parents, the mother, she was on anti-hypertensive medication, namely Redac and amlodipine. And when the family went back to the house, they actually found 2 empty boxes of amlodipine. So this is just a snapshot of the timeline of the case presentation that I'm talking about. So at 8 a.m., he ingested the tablets. Only 7.5 hours later, he presented to the ED. And then when the patient was reassessed at 7 o'clock, he was found to have persistent hypertension only. Fluid was given, but still remained hypertensive. So then at 7:30, the patient was moved to resus for monitoring, and the EM consultant was contacted. Sorry. So if we put the pieces of the puzzle together, it was concluded that this patient had taken a calcium channel blocker, and the patient was now exhibiting signs and symptoms of a calcium channel blocker overdose. So with regards to the mechanisms of toxicity, just before I rush into the treatments, I think it's important to understand why we give what we do and what we do in relation to the mechanism of toxicity of such an overdose. So just to keep it in the back of your mind that the manifestations of a calcium channel blocker toxicity are generally an extension of what the drug's therapeutic effects are. So if we go to pharmacology, as we know, calcium channel blockers directly antagonize the voltage-gated L-type calcium channels, and those are found in the peripheral vascular smooth muscle, the cardiomyocytes, and the pacemaker cells, which form the cardiac conducting system. And calcium channel blockers are divided into 2 main classes, namely the dihydropyridines and then the non-dihydropyridines. So if we go into the dihydropyridines, this class preferentially affects the vascular smooth muscle in the periphery, and therefore it decreases peripheral vascular resistance and reduces afterload, therefore reducing blood pressure. So that's why they are excellent agents for hypertension. And examples of these are nifedipine and amlodipine. Then with the non-dihydropyridines, this class is lipophilic and they have a higher affinity for cardiomyocytes. So they actually reduce the influx of calcium during the phase 2 of the action potential. And due to calcium not being able to enter the cell, the excitation coupling in these cells cannot occur. And so this results now in a decreased myocardial contractility. And this reduced binding of calcium in the calcium channels in the conducting system then leads to the slowing of the SA node, the AV conduction, and therefore you get a bradycardia. So that's why we use these agents to treat the anginas or your cardiac arrhythmias. So these are your verapamils and diltiazymes. Okay, so with toxicity now and calcium channel blockers, so as we know, calcium plays an integral role in the myocardial function, and it's necessary for automaticity, conduction, contraction, and vascular tone. So the mechanism of calcium channel blockers is that they bind the alpha-1 subunits of the L-type calcium channels, thereby preventing the intracellular influx of calcium. And then these channels are functionally important in cardiac myocytes, vascular smooth muscle cells, and even your islet beta cells, which are found in the pancreas. So these are your 4 main organs that that calcium channels exhibit toxic effects in a toxic in a CCB overdose. So you have your vascular smooth muscle, you have your cardiotoxicity effects, you have your neurological effects, and you have your metabolic effects. So in the amlodipine overdose, this affects your vascular smooth muscle tone, and you have a profound peripheral vasodilatation of the vascular smooth muscle cells. And this gives you this distributive shock. And a reflex tachycardia usually happens in distributive shock, but in calcium channel blocker overdose and at toxic doses, this fails to occur because these dihydropyridines lose the preferential selectivity for the peripheral smooth muscle. And instead, they cause a bradycardia and cardiogenic shock. So if you just think back to how this patient presented, the actual receptor selectivity was lost, and he actually developed this cardiotoxicity and vasodilatation from that large amlodipine overdose. Then with the non-dihydropyridines, they cause the cardiotoxicity effects, and that includes the bradycardia, the AV blocks, hypertension, and the cardiogenic shock. So in essence, I just want to say that the hallmark of a CCB OD is the circulatory shock, which is caused by your bradycardia, your poor cardiac contractility, and then also the profound peripheral vasodilatation. Then neurological effects is actually quite a late feature of toxicity. It's more due to the cardiovascular lapse, where there's hyperperfusion of the brain due to hypotension, and this may actually cause impairment in consciousness, and sometimes you can also witness seizures. And then lastly, your metabolic effects. So like I said, they also have, calcium channel blockers also have effects on the L-type calcium channels in the beta islet cells of the pancreas. So they actually prevent insulin release. And this results in the hyperinsulinemia and therefore insulin resistance. And that's why they present with a hypoglycemia. If you remember the ABG that I showed you initially on one of the first slides, he had an HGT of 13.8. And then further metabolic effects is that the cardiomyocyte response. So instead of using free fatty acids, in the toxic state, they actually use carbohydrates as the energy substrates. And therefore, the liver releases the glucose via gluconeogenesis. So that also results in your hypoglycemia and your poor cardiac contractility. So if we go back to our case, The patient was moved to resus. He was started on HIT, as discussed with the consultant. But I just want to break down that in any toxicology case, it's good to have an approach so that you don't miss anything. And this is how I've broken down the management into the different headings. So number one, resuscitation. This is what we do in the ED. And we always manage the patient by addressing the ABCs. So in such cases, especially in CCB-OD, it's important to insert a central line early, as well as having peripheral vein access, because as I'll go through the specific management, you'll understand that why you need such access. Also noted, in critically ill patients, it is a good idea to have a controlled airway, but these patients usually have hypertension and myocardial depression, and intubation with induction agents and PEEP can actually exacerbate these symptoms. So always important, I think it's a rule of thumb, you need to resuscitate your patient before you intubate your patient. If you do have to intubate, we always do RSI in the ED, but I do recommend using perhaps half dose of ketamine, so 0.5 milligrams per kg, and then you'll need to use higher doses of paralytics because of the poor muscle perfusion. Then with regards to specific treatments, these are needed to support your cardiovascular system. So number one is your fluid management. And generally, in my experience, I'm just cautioning about fluids, but you can give a bolus of up to 20 mL per kg. It's just important to note that these patients are prone to non-cardiogenic pulmonary edema because they develop a pulmonary vasodilatation and they actually get alveolar extravasation of fluid. So excessive fluid resuscitation may actually compound this. Then secondly, your calcium replacement. Going back to how the toxic mechanism is, we want to give calcium because the calcium influences the heart rate as well as your blood pressure. So you can either give your calcium gluconate or your calcium chloride. Just make sure that you try and keep your ionized calcium on your gases to above 2. Atropine can be used for CCB-induced bradycardia, but it is often ineffective. You can give 0.6 milligrams every 2 minutes for a total of 3 doses. Then glucagon boluses. This is quite controversial in the tox world, but there isn't actually a proven role in calcium channel blocker OD to use glucagon, but it may be of benefit in beta blocker overdoses if you can find sufficient quantities. And I know I'm coming from state. I think you can maybe perhaps find one in the fridge. It's very expensive and patients do present with severe vomiting as a side effect. This may be different in private and there's a lot of, like I said before, there's a lot of controversial glucagon boluses within the tox community. And it is still in most of the international expert guidelines. And then with vasoactive infusions, vasopressors are more likely to be useful if there is vasodilatation that is significant, whereas insulin and inotropes are more likely to be beneficial when there's impaired contractility. So during the Essentials of EM this year, I listened to one of the talks and the presenters actually stated that the pressor doses need to be very, very, very high, and that there really isn't a ceiling dose for vasopressors, which is quite, I don't know, for me, it's quite, I suppose it is quite scary going up to what, 2, 3, 4 mics of adrenaline. So they actually suggested starting with noradrenaline and then adding a vasopressin and then adrenaline. In our public setting, we don't always have noradrenaline. It's quite rare, but I think in private, if you do have noradrenaline and you have it in stock, I would seriously consider starting rather with noradrenaline than adrenaline. But if adrenaline is all you have, that would be considered appropriate. And then lastly is HIT, which stands for high dose insulin euglycemic therapy. And that is a topic all on its own, which we'll jump into right now. So HIT is considered a useful treatment strategy in the management of cardiovascular toxicity in CCB-OD, as it provides a backdoor for inotropic support. And although the mechanism is not fully understood, they explain the rationale in 3 different ways. So number 1, it acts as a catecholamine independent inotrope that acts directly on the cardiomyocytes. Then secondly, it also enables the uptake of glucose into the cardiomyocytes, which is the heart's preferred energy substrate, especially during stress. So since calcium channel blockers in overdose produce a hyperinsulinic state, the glucose uptake into the cardiomyocytes cannot occur, and therefore it impairs cardiac contractility. So using exogenous high-dose insulin as well as supplemental glucose, therefore enables the cardiomyocytes to uptake the glucose, and therefore it improves the myocardial contractility. And then lastly, they suggest that insulin acts as a peripheral vasodilatator, which reduces afterload but improves systemic perfusion. So in your coronary arteries, this vasodilatory effect, it improves perfusion and oxygen delivery to the heart, and thereby improving inotropy. So this is just a flow diagram of just showing how HIT works on either the myocardium and vascular smooth muscles, and then also the pancreatic B cells. So HIT should be initiated in symptomatic patients as early as possible to improve hemodynamics of a patient, as well as to help taper inotropic infusions. So how do we do this in the ED? So I've put a nice little flow diagram here. So number 1, we will commence therapy with a 50% dextrose water IV bolus, unless the patient's HCT is more than 16.7 millimoles per liter. And then you're also going to give a short-acting insulin, 1 international unit per kg bolus to saturate the insulin receptors. And then number 2, so we're now going to continue therapy. So you continue with a short-acting insulin infusion, and you start at 0.5 international units per kg, and you can titrate up to a max of 10 international units per kg per hour every 30 minutes. And I know these are massive doses of insulin. And just some practical tips on how to actually mix these infusions, because we only know the DKA protocol of 0.1 international units per kg per hour. So if you take a 200 ml normal saline bag, you take out 20 mils from that, and you put in 2,000 international units of insulin, your concentration is then going to be 10 international units per ml. And you're going to start the infusion at 1 international unit per kg per hour. So for instance, if it is a 60 kilogram patient, you're going to start that infusion that we just mixed at 6 mils per hour. So the patient will essentially be getting 60 international units per hour of this high dose insulin. And then also important, you need to commence 10% dextrose water to maintain normal glycemia, and you may need to change this to a 50% dextrose infusion to prevent neuroglycopenia. And then this picture here is actually a picture of this patient that I managed, and you can see that there are there's multiple infusions happening here. So number one, like I said, during resuscitation, it was important to put in a CVP line and have peripheral lines running so that you have access, and you need access for all these different infusions. And then, like I said, monitoring. So glucose, you're going to check every 20 minutes for the first hour, and then every hour. And then the potassium, you only replace the potassium if it's less than 2.5 millimoles, and if there's actually a source of potassium loss. And then just monitor your magnesium as well. It should be checked and replaced if low. So then we come to the maintenance. So this is now increasing your insulin infusion. So you can increase it up to 10 international units per kg per hour until you have hemodynamic stability, and that means the therapeutic endpoints. So your therapeutic endpoints, a lot of us in the ED work with ultrasound machines. So if you can check the ejection fraction, if it's more than 50%, this is one of your therapeutic endpoints. However, some of us, if you don't know how to use an ultrasound, that's also fine. You can also check that there's an improvement in the patient's systolic blood pressure of more than 90, that they have an adequate heart rate of more than 60. You will see that the acidemia improves, and they also maintain euglycemia. Their urine output would be 1 to 2 mils per kg per hour. If you check on the ECG, the cardiac conduction abnormalities will have resolved. The QRSs would be now less than 120 milliseconds, and the mentation will also have improved. So with regards to maintenance, I know I said up to 10 international units per kg per hour, but there are case reports of up to 22 international units per kg per hour, which have been safely and effectively used. And the highest dose used for this specific patient was 10 international units per kg per hour. But in other patients that I've managed, I have gone up to about, I think it was 16 international units per kg per hour. So these are very high, scary doses. But if you taper this therapy to effect, it actually works, but it is very intricate, and you have to keep your wits about you. And then lastly is your transfer. So you can either transfer to a high level care of monitoring. As you can see, these patients need, especially if they're intubated, they're running all these different infusions, they definitely need an ICU, either in your hospital or in a referral hospital. And then some other treatment options to consider. So we have the intralipids. These are also quite controversial and are used as a last resort. But with regards to calcium channel blocker, because they are protein bound, the compound's supposed effect is to mop up the compound and then try to decrease the toxic effects. There are a few evidence cases where this has actually worked, and the initial bolus were, so when you have intralipid, you give an initial bolus of 1.5 mils per kg, and then you'll start an infusion of 0.25 mils per kg per minute for 30 to 60 minutes. Not all of us have intralipid in the ED, but if you need to find this, you can always check in theatre. And then our next ones are the phosphodiesterase inhibitors, and these increase intracellular cyclic AMP, without beta receptor stimulation. So with this increased intracellular cyclic AMP, this leads to increased intracellular calcium and improved inotropy. But however, with this increased cyclic AMP concentration, it also increases your vascular smooth muscle, the concentration, and then this actually results in vasodilatation. So this can make your hypotension worse. So they're only used as third-line agents. Cardiac pacing could be another modality, but electrical capture can be quite difficult to achieve and may not improve overall perfusion. And then there's a cool one called albumin hemodialysis. So these are more case reports that I've read about. Because amlodipine is quite a highly protein-bound drug, and the use of some form of albumin dialysis technique seems strongly rational. The simplest system is called the single-pass albumin dialysis, which uses your standard CRRT, but blood is actually dialyzed against an albumin-containing dialysate. But like I previously said, only case reports have been published, but this may become the standard of care in future. And then circulatory support devices. So ECMO has been used in amlodipine overdoses as a life-saving measure, but it's only used in patients who are refractory to other standard medical treatments. So there have been case reports of the veno-arterial ECMO, and that allows gas exchange and hemodynamic support. And it is a potential rescue therapy in CCB poisoned patients that are presenting in cardiogenic shock or a mixed shock. And although case reports on its use have had positive outcomes, in our public setting, this is often unavailable, but I think in private where you work, this could possibly be an option, especially in those cardiotoxic patients when your back is against the wall. I would definitely go for ECMO. And then decontamination. So activated charcoal, we all know about, and it can be given to the asymptomatic patients. Just important to note that it can be given within 1 hour for standard release preparations, but also for the sustained release preparations, you can give it actually within 4 hours. And then there's something called whole bowel irrigation. Not a very big topic in our South African setting, and also quite a controversial topic in the toxicology world. And the Poison Review, I'll just give you a quote of what they said, that there actually hasn't ever been an adequate clinical trial looking at the potential risks and benefits of whole bowel irrigation in patients who have ingested large doses of toxins. And therefore, all the potential benefits of whole bowel irrigation are theoretic, whereas the risks such as aspiration or gastrointestinal ischemia are quite real. So I've never personally used this in the ED. I'm not sure if this is being used in private, but I don't think it has been. And then enhanced elimination, unfortunately, no measures to enhance the elimination of any CCBs in toxic patients. So just remember, like I said, disposition, the patients who are toxic, they need to be in a very well monitored bed, so either a high care or ICU setting. Asymptomatic patients, remember, they often decompensate because of the half-life of the calcium channel blocker within 12 hours of ingestion of a toxic dose. So they need to be monitored, even if they are asymptomatic, for at least 4 to 16 hours. And then also don't forget that you need to do a psychiatric evaluation once the patient is stable, especially those patients who have taken an intentional overdose. And then some complications. So I've just divided the complications into two. So the first group the first group of complications that can arise from the calcium channel blocker toxicity itself, and that includes the cardiogenic or the distributive shock, and all these effects on other organ systems, which can lead to the renal failure, your mesenteric ischemia, your pulmonary edema, and even cardiac arrest. And then the other group is complications from the treatment. So in HIT, patients can become hypoglycemic, hypokalemic, even hyponatremic, and sometimes present with hypomagnesia. Just important to note that they can also develop limb ischemia if ECMO was a treatment used. So just some final thoughts. So just rounding off the case presentation, this patient was treated in the ED by myself and another MO for, I think, the duration of my whole 12 hours that I was on shift. He was given specific treatments, including calcium, HIT, sodium bicarb, and an adrenaline infusion. A last resort, he was even given intralipid therapy and he was transferred to ICU. Unfortunately, after 11 days, the patient demised of nosocomial sepsis. So I just wanted to highlight some learning points about this case. So there was a concern about the severe acidosis when I was resuscitating him that he developed, and I actually gave too much fluid. So he developed this severe pulmonary edema, and he required intensive ventilation strategies, very high PEEPs. This was a few years ago, so like even proning him was something unbeknownst to me. So he was very difficult to ventilate with this extreme pulmonary edema. And then I think we should have started HIT much earlier so that the effect could start working faster. So like I said before, the turning point or the decompensation is usually 12 hours post-ingestion, especially in amlodipine ODs. So if you can start HIT prior to this, it will actually decrease your dosage of inotropes and the patients actually stabilize much faster. So remember, he waited about 7.5 hours even to get to the ED before from his original ingestion. And then he was only started on HIT when he moved up to resus, which was almost 12 hours post, and that's when he decompensated. Also, we were super concerned using these high doses of insulin and all the infusions. So it's quite important to keep track and keep your wits about you. So labeling the infusions, the actual lines are either put stickers or some slick on and like label each one, because sometimes you can get a bit confused with all the different infusions that are running at the same time. And then also limited resources. These patients, you have to be quite vigilant with them. They need tedious bedside monitoring, and this can be quite tough, especially now in our current situation, the fourth wave with all the COVID patients. You cannot divert your whole time to this one patient, which essentially needs all these resources. So it can be quite daunting and stressful. Yeah, that's my presentation. These are just some of my resources, my references that I used. And yeah, if you guys have any questions, I'll be happy to answer. Thanks for listening.
Thank you very much. It was really, really brilliant, and I love your theme. Is there any questions, any comments from anyone, please? It looks like you've explained very nicely. Okay, cool. Thank you very much, and we really appreciate your time and your effort. Yeah, so we'll see everyone next year for the new lecture series in the new year. Please stay safe, take care of yourself, and look after yourself. Thank you very much.